Hello, today I will be presenting case study number 26, nausea and vomiting. My name is Holly Bradley, and I will be presenting this for Nursing 711. We're going to start off on slide 2 with the chief complaint and the history of present illness post-op to day 5. The patient's chief complaint: I've been nauseated again and have thrown up several times since yesterday. I also have a constant aching in my stomach and I feel really bloated again. His history of present illness: he's an 83-year-old male, elective repair for a AAA, 5 days post-op. He had 9 hours of uncomplicated surgery. IV methyldopa was used to maintain his systolic blood pressure below 160 millimeters of mercury. He had IV morphine sulfate for pain every 90 to 120 minutes. His vitals were stable for the next 5 hours. Then he noted moderate abdominal distension, soft. He had no bowel sounds on auscultation, no fever or elevated white blood cells, but mild tenderness with palpation. The plain film showed cecal diameter of 10.5 centimeters, which is the upper normal range. He was diagnosed with acute colonic pseudo-obstruction secondary to surgery. An NG and rectal tubes were placed with low constant suction provided. The patient periodically was rolled side to side and prone to promote expulsion of gas from the colon. NG output was replaced milliliter for milliliter with IV fluid of 0.45 normal saline with 20 milliequivalents of potassium chloride. Post-op day 1, repeated abdomen x-ray showed cecal diameter unchanged at 10.5 centimeters. The patient continued with nausea and vomited twice. The NG output was measured every 4 to 4.5 hours with a range of 50 to 175 milliliters of green drainage fluid. Post-op day 2, analgesia with morphine, maintained IM. Now, cecal diameter had shown an increase to 11.5 centimeters. Vomited again twice. Received 2 milligrams of neostigmine IV with resulting colonic decompression in 20 minutes. He was monitored for related neostigmine bradycardia, which did not occur. Post-op day 3, cecal diameter decreased back down to 9.5 centimeters. The patient felt less nauseous, no vomiting for 12 hours. The NG output decreased to 60 milliliters over an 8-hour period. He remained on the same IV fluid and was NPO. Abdomen showed mild distension, soft, but he had bowel sounds all 4 quadrants, and the plan was to maintain the tubes for another day. Post-op day 4, the tubes were removed. He was placed on a clear liquid diet in the morning, but by 12 p.m. he had increasing abdominal pain, bloated, nausea, and vomited times 3. Respiration rate at that point was 28 per minute, heart rate of 105 per minute, and the blood pressure and temp remained normal. Bowel sounds were now absent. He did not respond to further neostigmine as previously, however, responded well to decompression tube placement. Within 18 hours, his symptoms returned again. In our next slide, we're going to discuss metabolic alkalosis, the definition. So metabolic alkalosis is the increase of both plasma bicarb level greater than 26 and blood arterial pH greater than 7.43. It occurs frequently and is typically accompanied by hypokalemia. Respiratory compensation is minor in patients presenting with a metabolic alkalosis. The most common causes are loss of gastric acid secondary to vomiting or nasogastric suctioning, and/or loss of intravascular volume and chloride as a result of diuretic use. This patient was not receiving diuretics, as a side note. Patients receiving parenteral nutrition may develop a metabolic alkalosis from excessive acetate and inadequate chloride in the formulation. Again, this patient was not receiving this, but this is also a way to become diagnosed with metabolic alkalosis. Acetate is metabolized to bicarbonate, which leads to the alkalosis. A metabolic alkalosis can be classified into volume-mediated, which is saline responsive, and volume-independent, which is saline resistant. Metabolic alkalosis pathophysiology at the cellular level for this patient. Hydrogen ions may be lost through the kidneys or the GI tract. Vomiting or nasogastric suction generates metabolic alkalosis by the loss of gastric secretions, which are rich in hydrochloric acid. Whenever a hydrogen ion is excreted, a bicarbonate ion is gained in the extracellular space. Stomach fluids are highly acidic at a pH of approximately 1.5 to 3.5. Hydrogen secretion is accomplished via parietal cells in the gastric mucosa. Therefore, the large volume loss of gastric secretions will correlate as a loss of hydrogen chloride, an acidic substance, leading to a relative increase in bicarbonate in the blood, thus driving alkalosis. Losses can occur pathologically via vomitus or nasogastric suctioning. In general, the causes can be narrowed down to an intracellular shift of hydrogen ions, GI loss, and GI loss of hydrogen ions. In our next slide, we'll review clinical manifestations of metabolic alkalosis for our patient. The subjective data we reviewed already in the HPI and the chief complaint, but for him it was abdominal bloating, pain and distension, nausea, vomiting, symptoms following his AAA repair. He has a past medical history and past surgical history. Past medical history, type 2 diabetic, hypertensive. Past surgical history, he had a right nephrectomy and a partial colectomy. His social history is unremarkable. Medications include amlodipine, glyburide, enteric-coated aspirin, and gemfibrozol. He has no allergies. The objective data that was presented showed a lack of bowel sounds, X-rays resulting showing colonic pseudoobstruction, NG tube and rectal tube placement, further loss of fluids related to tubes and vomiting. His vital signs were normal. Then he became hypotensive, tachycardia, increased respiratory rate, and just as a side note, respiratory alkalosis potential here. And his weight-height ratio, he was thin. Labs, as far as abnormals go, the sodium was elevated at 147, the potassium was low at 3.2, the chloride was also low, the BUN is elevated at 30, the bicarb at 31, and the PO4 just below normal, and the white blood cell count was low at 3,500. We don't know exactly when these labs were taken or if they were repeated. Abnormals upon physical exam, he was ill-appearing, ashen face with sunken eyes, his skin colored gray, dry, poor turgor, lungs tachypnea, cardiac sinus tach. Abdominal exam showed moderately distended with hypoactive bowel sounds, pain with light palpation in the right lower quadrant. Musculoskeletal exam, pulses were hypoactive at 1+. In his neurologic exam, he was lethargic, all symptoms of metabolic alkalosis. This patient exhibits metabolic alkalosis secondary to surgery. Age is a factor, dilated cecum diameter, nasogastric loss of fluids coupled with vomiting, with the lab abnormalities of hypokalemia. He also illustrates the need for electrolyte rebalance and further intervention by remediating the underlying cause. We need to keep in mind, too, that the fact that he only has a left kidney, most likely dehydrated, and maybe also heading into respiratory alkalosis. Slide 6, role of the advanced practice nurse. So the role of the MP in this situation would be intervention of the fluid imbalance, continued IV with added potassium, administration of an antiemetic such as Zofran, pain control, monitoring all labs with adding a pH and arterial blood gases. Also would measure all input and output to augment the acid-base balance, providing pain control and respiratory support. We'd also continue with surgical consult for issues with the dilation and colonic pseudoobstruction. We'd want to monitor skin integrity related to dehydration and weight loss. This patient is also a high fall risk. He could need parenteral nutrition, but that's also a contributory factor in metabolic alkalosis, so we would have to come up with a plan. We'd also like to provide support to the patient and family spiritually and emotionally through caring behaviors. Educate the patient and family of the current condition and have them engage in any care that they feel would bring comfort to the patient. Effectively communicating with compassion involves not only delivering a message, but also resonating with the experiences, values, and emotions of those listening. So we definitely would want to make sure that we could be compassionate with this patient, his family, and the current situation. Some questions for this case study for further discussion would be, is there any correlation with the patient's history of a partial colectomy and the colonic pseudoobstruction? Would providing the patient with parenteral nutrition help or hinder his metabolic alkalosis, and why? Does the fact he only has one kidney change your plan of care for treating this patient with fluids? And the last slide just shows references of the information that I obtained. Thank you so much for your attention to my presentation, and I look forward to listening to yours.